that I was a sort of fly on the wall for that last discussion because one of my burgeoning interests right now is in helping to develop informatics tools to make clinical research easier, including screening. And so as I learn more about those tools and think about how we can apply them to improve our efficiency, I will likely come back to this group. And if anybody has a particular interest in that, please let me know. You can get to me through Josie. Josie has my email, or if you can spell my last name, you can email me that way. But this was a fascinating thing to hear about how different groups are tackling this. There definitely, I think, are ways to use our EMRs potentially to help do some of this work for us. At least that's what I'm interested in. But for the moment, yep, I will do that just now. But for the moment, I'm going to talk about transfusion. And Josie needs me to figure out how to share the slide deck, which means I have to get to the Zoom controls, which are somewhere hidden. Here we go. Share. Let's try that one. Okay, we good? Okay. Perfect. Maybe not. Okay. Now the question is, did that advance on the Zoom? Is anybody on the Zoom? Or anybody online?
I can see it.
Okay, perfect. Thank you. Okay, so we'll switch gears here and talk a little bit about transfusion. Josie asked to come talk about transfusion. Like, well, okay, there's a lot that could be talked about for transfusion. And so I thought I would focus a little bit on what we think we know and a lot of what we don't know, and actually highlight some of the things that have come out of the PALISI network over the last, well, almost 20 years now. So that's why I titled this What We Do Not Know. No disclosures. Okay, quiz time. Anybody take a guess? We'll say within a decade of when the first blood transfusion was. I don't have any fancy prizes, but just throw out a guess. All right, we have a 1910. Earlier or later? What do you think? Oh, we have thoughts for later. Okay.
1940.
1940. All right. These are all good guesses. And certainly, we're thinking around, combat and wars and things like that. Certainly, where a lot of the advances in transfusion medicine were. In fact, technically, the first transfusion was in 1665 between two dogs. The first transfusion of blood into a human was in 1667 from a lamb. And the first human-to-human transfusion was in 1795. A little fun fact. Now, clearly, we know a lot more now than people did then, and transfusion was quite dangerous then. At that point, people didn't know about different blood groups and compatibility, and the fact that I can't just pick any random person and have them give blood to another random person. You have to know about the blood. But just sort of an interesting factoid that there's a very long history of transfusion. So we're going to highlight each of these objectives. In the interest of time, I don't know that we'll spend a whole lot of time on all of them, because I wanted to provide a bit of a high-level overview. But I wanted to talk a little bit first about red blood cells and think about why we even transfuse red blood cells. And scenario number one is somebody's bleeding, you give them blood back. That's in some ways, I would say that's somewhat easy, but even that, there are still questions and ongoing trials to answer those questions of what kind of blood, when do you give, how much do you give, all of that, even for acutely bleeding patients. For the patients who have low blood counts or anemia that aren't bleeding, I'm not quite so sure. So one of the things that we think about when we're giving red blood cells in particular is the red blood cells are what carry oxygen. And so we think to ourselves, well, if really what we do in the ICU is to deliver oxygen, right? We have ventilators to get the oxygen into the body, we're supporting hemodynamics, supporting circulation to circulate that oxygen around. That's pretty much what we do. And there's math that tells us that increasing hemoglobin is the most efficient way to increase the amount of oxygen in the blood. And so it makes sense that more would be better. But in reality, maybe it's not. And so this actually, for those of you who aren't familiar with the TRI-PICU study, this was one of the first multi-site randomized clinical trials that came out of the PALISI network. It was Jacques Lacroix and the BloodNet subgroup published in 2007. So there were about 3 initial RCTs. If you guys see the history of PALISI slides that sometimes are a part of the chair update, you may see this one highlighted. But basically, what this study did was take a liberal transfusion strategy. So basically, if the hemoglobin was less than 9.5, which is still a little bit lower than normal, that would prompt transfusion in one arm of the study. The other arm of the study was transfused to a goal of 7. And just over 600 children who were hemodynamically stabilized. So these weren't children who had acute shock. They weren't children with cardiac lesions. This was a PICU population, or at least not with cyanotic congenital heart disease. And the conclusion of the study was that there really was no difference in outcome between arms, either in the primary outcome, which was newer progressive multiple organ dysfunction syndrome. This was one of the earlier studies that used NP mods as an outcome measure, or in any of the other secondary outcomes. And so the overall conclusion was that a restrictive transfusion strategy is safe. And so now 7 kind of has become the magic number for transfusion in the ICU. A bunch of adult RCTs that have come to similar conclusions. If you look at transfusion for a high hemoglobin versus transfusion to a low hemoglobin, the outcomes tend to be similar. And there have so far been 7 RCTs. Obviously, TRI-PICU is the largest of those, with, again, similar findings. So I like to ask the question why. One of the things that drives me toward research and why I am passionate about what I do is that I want to know why. Like, it doesn't make sense. Why isn't maintaining a higher hemoglobin better? It should be, right? And so these are some of the thoughts. One is like, well, maybe it's that hemoglobin is the wrong target, okay? And so this was from an observational study that we did looking at kids with these were severe sepsis. And if you look, actually, this is an interaction plot, and it looks at the relationship between whether or not you had a red cell transfusion and your prediction of the number of days with organ dysfunction you would have over the span of shock index. So shock index is your heart rate over your systolic blood pressure. So high is bad. And these were age normalized. Basically, what it tells you is if your shock index was essentially normal, not in shock, then getting a red cell transfusion was associated with worse outcomes. If, however, your shock index was high, you have a higher degree of shock, well, then getting a transfusion might have been associated with better outcomes. And this kind of makes sense, right? So instead of targeting the hemoglobin, thinking about targeting the hemodynamics, like, is it the degree of shock maybe that we should be using? And it turns out if you do the same thing with hemoglobin, at no point along the range of hemoglobin do those lines cross. So perhaps hemoglobin isn't the right measure. It might also be that red cell doesn't always work. And so there are lots and lots and lots of studies about different types of red blood cell products and their ability to actually offload oxygen and improve oxygen delivery in the body. There are probably patient-related factors as well. And so this was just a quick proof of principle small study that we did that looked at whether or not the shock index actually improved after a red cell transfusion. And the take-home message of this figure is that for some patients it did, and for some patients it didn't. So basically, not everybody reacts the same. That's the important point of this slide. So it also might be that even if there is some benefit, there may be risks to transfusion. And so everything that we do is about a balance of risks and benefit. And so I'm, in the interest of time, not going to go too far into depth in the risks of transfusion, other than to say that the things on this slide are all the things that we tend to think about. Hemolytic reactions, infection, they're the things that when the folks ask parents for consent for blood transfusions, these are the things they list. These things tend to be relatively rare. In fact, in newer data suggests that they're also rare. This has been a lot of the advance of transfusion medicine over the last couple centuries, is to make transfusion safer. I'm going to skip through this for a moment to get to some of the things that we don't know as much about, however, are the things that are harder to measure. So the things that we can measure, we can say, yep, the transfusion definitely did that. Those are relatively rare. Other things are a little bit less clear. So we know, for instance, that blood products do change immune cell function if we put them in a petri dish and expose those immune cells to blood products. And they do so in different ways when we look in patients. So if we look at observational studies, there are some studies that suggest that red blood cell transfusions might be inflammatory, cause higher inflammation. Some, they may be immune suppressive. Blah, I should be able to say the word immune suppressive. And some that are mixed, like it just depends on the patient, depends on the blood product, it depends on what arm of the immune system you're looking at. And so a whole lot of mixed results. And whenever you hear the word mixed results, think, we don't know. There's a lot that we don't know. And I also think that it probably has to do with the combination of the blood product, but also the patient itself. So it may have to do with what is the immune or inflammatory state of the patient at the time that they're getting that transfusion. Maybe that also matters. And we do have a little bit of data to suggest that that may be the case, that it may be that those patients who are already immune suppressed at the time that they get their transfusion might be at higher risk of further immune suppression or of not recovering that immune function. And so that's sort of the take-home message of this slide here. So this is from another observational study that we did that indeed suggests, again, you see that interaction plot. Anytime you see a plot like that with lines that cross, it means that there are some patients that do better, some patients that do worse with the same intervention. This is going to be a theme. So we know that transfusion is not risk-free. Most of the known risks are rare. The other ones are harder to identify, particularly in the ICU, where we have so many things going on that give similar risks. And so I'm going to go back to that why question. And one of the reasons that I think why the randomized controlled trials of transfusion strategies up to this point have not necessarily been helpful in answering the question that I want to know at the bedside, and that is, this kid in front of me, should I transfuse you or not? Is that one of the things whenever you do any randomized controlled trial, statistically speaking, there is an assumption. And that assumption is that basically what you're doing when you do a trial is you're taking a sample of a population, right? So you want to ultimately answer the question for all critically ill children. Obviously, you can't enroll every single critically ill child across the world into your study. That would be impossible. And so what you get is a sample. And you're going to apply a therapy to that sample and you're going to measure the effect. And you're assuming that the effect is the same across that sample, because what you get at the end of the day is the average effect. You're going to get the average effect in that sample, okay? And so a fundamental assumption of randomized controlled trial study design is that the effect across the population of your therapy is the same. We live and breathe and work in the ICU. And I can really not imagine much of any scenario where that assumption holds true, right? Our patients are all very different. I think particularly in a pediatric ICU, right? There's already something different about a child when they get sick enough to be in the ICU. And so this is probably our reality, is that within that sample population, we have some patients who benefit from that therapy, some patients who are actually harmed by that very same therapy, and then other patients where it doesn't matter. And so when we hear about precision medicine techniques, or I'm sure at some point during the meeting this year's, you'll hear about ways to try to sub-phenotype our patients, really try to understand the underlying biology that may be driving this heterogeneity of treatment response. Because what I want to know is who's in that red circle and who's in that green circle, right? Like it matters to me less what the average effect across that population is. I'm going to know for this kid in front of me, are you in the green circle or the red circle? Am I going to make you better or am I going to make you worse? And so for those of you who are helping out with the tropics study, first of all, thank you. This is basically why we're doing the tropics study. For those who are less familiar, just briefly, the overall goal of tropics is to do exactly that. It's to identify clinical factors with biomarkers to try to see if we can build machine learning models to identify who's in that green circle and who's in the red circle. And this is, it is up to date. We added UCSF just recently. This is where we're enrolling, and we are something more than 260 patients in. I'll have updated numbers by tomorrow. And actually doing well. So in the meantime, while we're doing all these studies to try to figure out the question I want to know, I still have to answer that question every day in my mind, because I have patients that I have to decide, am I going to transfuse you or not? And so there are guidelines. These are the most recent published guidelines, that the pediatric version of which really actually came from this. This is another PALISI product. So the TAXI guidelines came out of the BloodNet subgroup of PALISI. And this was published actually in 2018. We really took what was known, not much, and some consensus opinion, and put together this guideline document. And what you'll see here, it's color-coded. And the colors that are important for the purposes of today is gray. Gray, as you could imagine, is we don't really know. Use your clinical judgment. And what you'll see on that screen is a lot of gray. Now, there are some things that we think we know, like if you're bleeding to death, transfuse. If you are stable and your hemoglobin is above 7, probably don't transfuse, we think. And there are certain cardiac conditions where there have been a couple of small RCTs. So if you're bleeding to death, transfuse. If you have a hemoglobin less than 5, probably should transfuse, although the hematologists who are looking at kids with severe iron deficiency anemia and starting to give IV iron instead of red cell transfusions are starting to question this notion even. So we are starting to see some of our kids with hemoglobins of 3, 4, that if they're stable, even those kids are not getting transfused. 5 to 7, no, we don't know. Over 7 and hemodynamically stable, we'll get to that in the next slide. Not hemodynamically stable, so you're in shock. We don't know. We haven't studied it. That's what we're trying to do right now. For kids who are hemodynamically stable, generally speaking, will probably not be transfused if the hemoglobin is over 7. But again, this is based on what we know now. It may be that hemoglobin isn't the right way to decide this, but it's just the way that the studies have been done up to this point. And let's skip through here. Cardiac folks have a little bit of a different set of parameters just because of the difference between cyanotic heart disease and non-cyanotic heart disease. So some of those patient populations will have a little bit of a higher hemoglobin threshold, but again, based on small studies, and there's probably a lot more to be learned from that population too. Okay, so in summary for the red cells, we think maybe less is more. but it's probably dependent on oxygen delivery and how well you are delivering and using oxygen as opposed to just hemoglobin alone. And probably the same strategy isn't going to be optimum for every patient in the ICU, probably, but we have a lot to learn. And thank you guys for helping us learn that. Okay, so that's the red stuff. A couple minutes on the yellow stuff. How do I have 10? Okay. All right, a little bit of the yellow stuff. So platelets and plasma. If you think we don't know much about red cells, we know even less about optimal use of platelet and plasma transfusions in the ICU. We know that they're given quite a bit. And so another PALISI study here that looked at it was a point prevalence study of plasma transfusion, plasma TV. You guys know, all studies have to have a catchy acronym, right? So you had TAXI for the guidelines, we got the traffic study. This was plasma TV. It was Oliver Karam's brainchild. So they did a point prevalence study. I believe this ended up being 101 institutions internationally across the PALISI network, and looked at reasons for plasma transfusion. The vast majority were given prophylactically, essentially to fix the numbers, not in patients who are actively bleeding. Same thing with platelet transfusion. I think that one was called PT3, platelet point prevalence transfusion study. Similarly, most of the platelets that are given in our ICUs are also prophylactically, and they're given for lots of different thresholds. So again, anytime you see a variation in the way that people practice, it's another sign for we don't know the right way to do this. What was intriguing, so we assume, kind of like we assumed that if you have more hemoglobin, you're going to deliver more oxygen, you're going to do better in the ICU. We also assume that, hey, you need platelets to clot. So if you want to prevent bleeding, you should give more platelets. This is a study not in PICU patients. It's in the place that starts with an N where the tiny babies are that then graduate to become our patients. But no, this was a NICU study that really kind of turned the field on its head a little bit. And I tell you, a lot of smart people have looked at this study trying to find fault with it. And it was actually a really well done study. But what they did is they took NICU babies and randomized them to get prophylactic platelets if their platelet count was 50,000 or 25,000. So like 25,000 threshold in NICU babies was like a really low. There was almost like, ooh, could you even do that study? Well, interestingly, their outcome was a combination or a composite outcome of death or major bleeding episode. The group that did the worst was the group in the high platelet transfusion threshold. So getting more platelets was associated with either death or major bleeding, which is, like I said, an interesting finding. And there are a lot of people now that are trying to go after the underlying biology of, again, why. It was a very unexpected finding, but really has made us all stop and think, wait, maybe we're not doing the right thing by giving all these platelets. And so, let's see, for anybody in the room who's part of the ecstatic trial, that's one ongoing pilot study looking at different platelet thresholds in ECMO. That's one of current BloodNet studies trying to answer that question of, when should we be giving platelets? In the meantime, we couldn't leave TAXI alone, so we had to do TAXI CAB. So TAXI, control and avoidance of bleeding, consensus recommendations for platelet and plasma transfusion. Because again, I still have to make decisions when I'm in the ICU, even though we don't have much data. And same thing here, you see a lot of gray on that slide because there's a lot that we don't know. But basically what we did was take what we do know and augmented by consensus opinion, came up with some guidance for platelet transfusion, similar to red cells. If you're bleeding to death, give blood products. There's a whole other set of guidelines around that, and randomized controlled trials about to be ongoing. I'm sure at least some of the sites here may be involved in MATIC 2. It's a going through PCARN. So it'll be the emergency departments, I think, doing most of that. But if you hear about that one, that's targeting this population. Oops, I went backwards. In terms of patients who are bleeding, the take-home message of this slide is that for a couple of patient populations, maybe keep the platelet threshold at 50. For most other patient populations, clinical judgment, that's a keyword for we don't know. So lots of, sorry guys, but there are research questions and potential studies for like every single one of those. So batten down the hatches. We'll see how many of these can actually get done. A little bit more has been done for patients who are not bleeding, although honestly, much of this was from consensus opinion, and there's still studies, I think, to be done. Plasma transfusion, pretty much the same. A lot of gray, a lot that we don't know about when to transfuse with plasma. Similarly, if you're not bleeding, there's a lot that we think we know, and we tend to be more restrictive with plasma transfusion. But honestly, there are some early studies now that are suggesting that there might be some patient populations, patients with either sepsis or other diseases that impact the function of the endothelium or the lining of the blood vessels. So pretty much inflammation of any variety that causes capillary leak. There might be a role for plasma transfusion, and those are potentially some studies that could be coming down the pike in the future. But for right now, we tend to be restrictive with plasma transfusion. And so we don't know a lot in terms of with confidence. We think that less is probably more, but there is lots and lots and lots of work to be done to even know how to predict who is at risk of bleeding, to know whether or not plasma or platelet transfusions or both or neither will improve that risk of bleeding or prevent bleeding, or even how to treat bleeding once it happens. So all three of those are big bucket categories of things that we don't know. So with that, what questions do you guys have? Yes, Josie.
This is just more of a curiosity than anything. So it was interesting looking back at the taxi study and then seeing that become sort of the standard of care, like what people reference. So I'm sort of curious how a study goes, like how you transform, how you take these studies and then transform the culture of the standard of care. Is that like a, is that through something like PCCM, or that like hospitals all agree to adopt a standard of care? Like what's the formality there of what becomes standard of care? Or standard of care at one site is different than another site. So I'm curious about that.
So that's a really good question. The question comes to, okay, you've done your RCT, or maybe you've done a couple of RCTs. You have the evidence. How does that evidence translate into practice? How do you change what people do based on the evidence? The short version of that is there is an entire field of science dedicated to that the Eclipse subgroup is really deals with implementation science. The slightly longer version of that is the reason that implementation science exists and implementation scientists exist is that is a very real gap. I think the most recent estimate, and this is not pediatric specific, but all studies everywhere, was something like a gap of 17 years between when you have evidence and when that evidence is fully incorporated into practice. And so there are entire fields of quality improvement and implementation science working to narrow that gap. There are multifaceted strategies to that. Part of it is dissemination, but we know that just getting the word out alone is not enough. And so it has to do with dissemination. It has to do with how to tailor specific guidelines to your environment, to your unit. What is it about your unit that's going to make it easy to adopt that? What's going to make it harder to adopt that? How do you overcome those challenges to adoption? And then it's about continuing to iterate to make sure that we're continuing to improve our practice even beyond the RCTs. That's basics.
So mine isn't so much a question, but just an observation from when we did a couple of these transfusion studies. And I'd love to like continue to talk as we go into more transfusion studies to understand how to better pitch it to parents. Because I think a lot of parents, when we were doing a study before, said, so you're telling me my child needs blood, but you're going to take blood first, because we wanted to see prior to transfusion and then after transfusion. So you're going to take blood, replace blood, and then take blood again. And I think families were kind of like, I'm not fully grasping this. And so as we go into more transfusion studies where we might want a pre and post transfusion sample, do you have any better ways that we can pitch this to families for why that's important?
Yep. No, it's a good question. Yeah, I think I know the study that you're talking about. It was because that was the one that was at the time that blood was already ordered. That one was actually almost a little bit easier because the blood was already ordered, and like the minuscule amount that you would take was like very, very small compared to the blood that your physician has already decided to give you. And so that was one way to help with that one. It's like, you're already going to be getting this blood, and it's orders of magnitude more than this tiny amount that we're going to take. And I think that's part of it. Is it's on us too, as investigators, to be judicious in what we are asking for and making sure that there's the minimum amount necessary. So certain things that we will say, particularly if there are concerns, are, that it is the minimum amount necessary, that it's been reviewed by the the IRB and as safe. We also by routine will run by the clinical team before we, and so like your doctors have said that it's okay to participate in this. But in terms of for the importance, I like to, I think there is something to be said for articulating what we don't know. That your child may or may not get a blood transfusion during their visit. We think we know some of the reasons why blood transfusions are helpful, but there's a lot that we don't know about that. And this can really help us to understand that better, to understand how to better treat critically ill children with our transfusion, so that we can make sure that what we're doing is helpful and not harmful. And that's how I don't know, Josie, if you would, or if Jill Jill's at the airport, so she just texted me. I know she's not on.
No, I mean, I think what you said is, that's not really a question that we've had come up, honestly. It wasn't really a concern that I've heard, or maybe once or twice ever. And I think part of it is too, because we don't try to emphasize it in a coercive way, but I think reminding people how small the amount of blood that we're drawing is. Like, it's so insignificant, really, to the impact of a blood transfusion and why someone might get a blood transfusion, that that there's always a risk, right? But there's really just no like comparison. Like there's really no impact or that we're aware of, just because the volume is so small. So again, I try to be careful of like how to word that. But when I talk to families, or when I have talked to families in the past, it's more like, it's like we're taking like a teaspoon of blood, and this probably isn't really going to impact. This is such a small enough volume that it really shouldn't impact why your doctor would choose to transfuse your child. Nor is it going to like take away from the benefits of a transfusion that your child would get. So I think just like including that in the discussion, as well as, just people, when they're in the hardest time of their lives, they love feeling like there is something good that can come from the bad thing that they're experiencing. And so helping them to understand why we're doing this, that we want to be able to make this so that future kids don't have to have their blood drawn, just to figure this out, and to make sure that they're transfused more safely and beneficially. I don't know. I feel like it was kind of a rambly response for not much being said, but yeah. And we're having, just so you guys are, if anybody, is anybody still on the WebEx? Because my computer is no longer connecting to the internet.
I see people here, and I
Interesting.
got a thumbs up from Lindsay. Hi.
Love it. Okay.
And Cindy raised a hand. Hi, Cindy.
Yay. So if somebody else can monitor for a minute while I try to reconnect.
Okay. Jen, I wanted to first, thanks for coming and talk to us. I wanted to ask you what your research origin story is and why transfusions were so like drawing and interesting for you.
My research origin. Oh, goodness. Okay. So I started out, let's see, the very first, I'm trying to remember what the very first research I did was with a neurologist in medical school that I don't remember anymore. But the first research that sort of set me on this path was as a resident working with one of our PICU attendings who was interested in immune function. And the big question that really sparked my interest and drove a lot of my passion for research was when you see patients with infection in the ICU and you see the huge spectrum, right? Like, why is it that one child can get pneumonia with either staph or strep and be able to be treated with antibiotics at home and be fine, and the other child is on ECMO? Like, there has to be something, right? And so it's that was the big why that initially drove my foray into research. And so I did a lot of, the inflammation and immune function work. Mark Hall was my mentor, still is my mentor to this day. And along the way, when I was a fellow, there was a paper in New England Journal of Medicine. It was a large observational study in adult cardiac surgery patients that showed an association between the volume of blood products that were given and nosocomial infection. And so there was a thought that, yes, there may be something about the kids that are different, but it might also be things that we're doing that are inadvertently impacting immune function. And so my initial work in transfusion was around that question: is our blood products immune suppressive in ways that might actually be impacting our patients? And as I was working on that, and my initial work was in the laboratory, I was doing in vitro transfusion studies. Then I realized, well, the question I really want to know is the question I just articulated. Like, I have a kid in front of me, do I transfuse them or not? And so that's what sort of took me into this direction of being a little bit more all-encompassing, out of just, does the transfusion impact the immune system, which interesting and important, but what I really want to know is, should I transfuse or not transfuse? And so I still have that question about the immune function that still drives part of my research program, but the transfusion part is focused more on that big question now. But yeah, that's a short version of it.
Can you hear me? Okay.
Yeah.
Mine's more of a comment, but I really appreciate you presenting on your research, although we don't do the study that you were talking about. I think it's important to hear from the PIs and like why they're doing what they're doing, because it helps when I talk to parents to explain like, yeah, like this is what they're trying to do. They're super passionate about this. Even when I'm like pitching like Paradigm, I talk about how like Precise, this randomized controlled trial, is coming out of this like other research. So it's really cool to see how the kids in this study are making a difference for the future. So other kids, we can find treatments and different things like that. So I just really appreciate you taking the time to explain it, because it helps.
Well, and I know, there was some conversation about, burnout and, workloads. And I agree with whoever said, set the boundaries. But I also, for me, that why is also a really good way to kind of help mitigate that as well. Because sometimes when you're in down deep in the details, and it's just the drudgery of day to day to day, to like pull back every once in a while and realize what we're doing and why we're doing it and why it's important. For me, that really helps me. And so hopefully that is helpful to you guys, because none of this happens without you guys. And if your PIs don't tell you this every single day, they should. But I will tell every single one of you in this room that what you do is so incredibly important, and you are all so good at it. We could not do this without you. So thank you from the bottom of my heart.
That's my hard time not qualified. It's in my
Yeah.
head. This is important. our division, our unit has decided that this study is important and we need more answers. So it's very hard for me to say, I can't do that one because we want to answer the questions. And if we can't get the patients, but when you said about one of the two of you about what to say to the families, I often will start with where we have gotten medically to be able to treat your child today is thanks to others who have participated in research. So that's, I'm here to talk to you about a research study that your child could participate in, may or may not benefit them, but will benefit the, community in general, like so that we can know going forth, are we doing what's best to care for these critically ill patients? And we hope we don't ever see you again or you with another child, but that, in the future, then we can give the best care. Know we did the best thing, but the why is why I have a hard time saying no.
Yeah, it's me too. That's why I have a hard time saying no. So, but I have to run over to the clinical research course now because also have a hard time saying no. But thanks everyone.
For those of you who this might